ado, let's talk about the speaker for the day. Outstanding Young Person of the Year 2020, Academic Lead in Oncoplastic and Reconstructive Breast Surgeon at the Royal Free NHS Trust Division of Surgical and Interventional Sciences, University College London, Dr. Jajani Susan Verghese. After completing her undergraduate education at PSG Institute of Medical Sciences and Research, she went on to do her MPhil epidemiology with a full Cambridge scholarship at Cambridge University, went on to do her MRCS from the Royal College of Surgeons, Edinburgh, and went on to complete a PhD in genetic epidemiology of breast cancer with a full Commonwealth scholarship at none other than the Cambridge University, UK. She then pursued with her FRCS plastic surgery at the Royal College of Surgeons, London, and went on to be a honorary clinical lecturer at the University College London. She has a vast experience of training and work at different hospitals, including Broomfields Hospital, Whipps Cross Hospital, Guy's and St. Thomas's Hospital, University College London Hospital, among others. In addition to being conferred with the Outstanding Young Person of the World 2020 in Medical Innovation from the Junior Chambers International at Yokohama, Japan, she has won first prizes for her posters in international conferences and travel grants for presentations too. With more than 15 international publications to her credit and 12 international and regional posters presented, Dr. Jajani is a truly global research champion. She was also invited to 5 international plastic surgery meetings in USA, Finland, and the UK. Dr. Jajani has made it her personal mission to attempt and restore the lives of millions of women affected by breast cancer. According to her, quote unquote, "Cancer will not defeat. We aim to restore people and lives. I can only search for the answers and heal the external scars. But ultimately, only God can heal the mutilations caused by breast cancer. I'm only an ordinary individual with an extraordinary urge to succeed and alleviate suffering. I count on excellence as the eventual result of a continual striving to do better. I count myself fortunate to be healthy, to love what I do, and to be able to help others." Brilliant plastic surgeon, impeccable researcher, scholar par excellence, and a radiant and humble human being, Dr. Jajani Susan Verghese, we welcome you to this program, to our international webinar. We are very fortunate to have you. Welcome, Dr. Jajani.
Thank you, Jacob.
And to moderate and to take over the session, we have none other than one of world's leading pediatric cardiothoracic surgeons and head of Believers International Cardiac Center, Dr. John Bulliett. Sir trained in cardiac surgery at the Queen Elizabeth Hospital, Birmingham, and has over 40 years of experience dealing with complex cardiac problems in adults and children. His areas of expertise include congenital heart surgery, minimal invasive surgery, and lean surgery, among many others. And he is the one who is going to introduce our moderator for the day. Again, a luminary, a doyen in plastic surgery, and he would be the best person to introduce him and hand over the session to our moderator. Over to you, Dr. John. Sir.
Thank you, Jacob. You may be wondering what I'm doing here, a cardiac surgeon, between 2 plastic surgeons. Well, myself and Dr. Thomas dreamed together in Trivandrum Medical College. He dreamed of becoming a plastic surgeon. I too dreamed of becoming a plastic surgeon. And both of us went to UK to train. He trained in clefts of the face, and I trained in clefts of the heart. And that is my interest in this. And I still think I am a plastic surgeon. I still pride myself in being the plastic surgeon of the heart. And that is why I'm here. My friend, Dr. Thomas, and as I told you, we were together in Trivandrum Medical College. And at that time, it was his dream. He was behind the plastic surgeon there. They were early days. And immediately after the MS, he got an assignment in Oman in a mission hospital. At that time, Oman was not as developed as it is today. And I believe there were only 11 kilometers of paved road there at that time. There was no electricity. There was no running water. And the American Mission Hospital was the only hospital in the whole of the country. and he joined there as a surgeon. And he stayed there until today. He became an Omani citizen, and he was taken to the government hospital, Howrah Hospital, which is the main hospital there, when the modern Renaissance started, and they started the developments and made government hospitals. And his work there was so impressive that when he asked to go to train in UK, they insisted that he come back after his training. So he trained in Oxford in plastic surgery, and he came back to the country, and he established the first plastic surgery department in the Gulf region. And it grew to be the biggest plastic surgery department in the Gulf region. And not only did he train a lot of plastic surgeons in the Gulf, he's traveled the world, and he has been with international charities like the Smile Train, and he was awarded the Omani nationality, and he settled there. And I was recently lucky enough to take part in the launch of his biography, which I'm showing you here, The Legacy of a Plastic Surgeon. So I think everybody should read it, especially young plastic surgeons, the journey where Dr. Thomas took and how he reached here. Now he's retired from the government of Oman, but he's still a consultant to the Astra group of hospitals. He works in Astra hospitals in Oman, and also he comes to India, to Kochi, actually, to do some charity plastic surgery. So I have great pleasure in introducing Dr. C. Thomas, my long-term friend and a pioneer in the field of plastic surgery. Dr. Thomas. Dr. Thomas, I request you to give an introduction to Dr. Jedini's talk, which is about oncoplastic surgery, reconstructive surgery, which as it evolved over the years in your experience. Dr. Thomas, can you unmute yourself, Dr. Thomas?
Yeah. Okay, fine. Thank you. Hi, Dr. John, and my dear friends. I express my many thanks to Dr. John and the members of the organizing committee for this kind invitation, especially. And it's a great pleasure to see a young, dynamic plastic surgeon with a upcoming and going to be a world famous one too. As mentioned in the introduction by John, I was in the head of the plastic surgery service in Oman. At present, I am working in the Astra Al Rafa Hospital, Muscat, and also in the Astra Med City, Kochi. I was told by my friend John to say about the general plastic surgery with the introduction of the oncoplastic surgery. And there I will exactly do what I was told. Friends, reconstruction of an amputated nose by a forehead flap is the first plastic surgery operation ever recorded in the medical literature. Way back in the 6th century BC, by the Sushruta, the famous plastic surgeon, Indian plastic surgeon in the northern part of India. Still, that flap, the midline forehead flap, is known as Indian midline forehead flap, and hence it is believed plastic surgery is originated in India. In comparison to many surgical specialties, plastic surgery, it is not a system-oriented surgery, but it is a technique-oriented surgery. Many of the surgical specialties is going after the system. For example, my friend John is a cardiothoracic surgeon. That shows he is dealing with the cardiothoracic system. And another one, urologist, is dealing with the urogenital system or by genitourinary. So every surgeon is related to a system. Whereas what about plastic surgery? It is no system. It is a technique oriented. And the word, how the word came plastic, it is originated from a Greek word plastikos. And the meaning is, one meaning is about to reconstruct or to restore. So operations which are designed to reconstruct or to restore the functions of a body or the organ, these are all categorized under the term reconstructive operations. And the second meaning of a plastikos is to mold, to give a shape. So accordingly, operations designed are known as cosmetic or aesthetic surgery. And these are the two main divisions of plastic surgery. That is, one is reconstructive operations, one is aesthetic or the cosmetic surgery operations. Common reconstructive operations are designed for the congenital abnormalities such as cleft lip, cleft palate, and the deformities of the craniofacial region and the injuries, and the, for example, burn management and the road traffic accidents, and of course, microvascular surgery. And the new addition, that is the one, it is the oncoplastic surgery. That means cancer surgery and its reconstruction. When I was a student in the medical college in Trivandrum, I have witnessed a cancer cheek, which is very common in Kerala because of the tobacco chewing. And the surgeon will perform a radical surgery of the cheek and the clearance of the nodes and discharging the patient with the orocutaneous fistula, with the constant dribbling of the saliva. And a second stage operation was planned or designed for the reconstruction of the cheek. But this is not acceptable to the modern world. Now we know any deformity even for the clearance surgery, if you are doing a radical surgery, reconstruction to be performed in the same sitting and the patient to be sent back to the ward without any deformity. That is the acceptable norm to the modern world. Why this is due to? We can see if you are creating a deformity and sending the patient back, it is an impairment of body image, and it has a great impact on the emotional stability. And the third one is a psychiatric cause. The patient will always having a constant fear of the deformity. By all these things, now it is worldwide unanimously agreed, any malignant lesions, if you are excising, it should be reconstructed in the same sitting. This is applicable to craniofacial surgery. I have done a lot of, for example, malignant lesions of the craniofacial regions, and also the reconstruction should be done in the same sitting. And the plastic surgeons, today's plastic surgeons, are blessed with many avenues how to reconstruct any type of defect by the different types of flaps. It can be a pedicled flap, or it can be a distant flap, or by the microsurgery, that free tissue transfer. So they are today's plastic surgeon is in a commendable position to perform the reconstruction in a different ways so that the patient can be sent back without any gross disfigurement or deformity. With this much introduction, I am just inviting our guest speaker of the day, Janie, to say about the latest techniques of the breast surgery and its reconstruction. Now it is for Janie. Thank you.
Thank you, Dr. Thomas. That was brilliant. I'm just going to start with sharing my slides now. Okay. So I'd like to start by thanking the whole team behind this Best Talks at the Believers Hospital, especially Dr. Jacob Jasurin, who I know very well from PSG Medical College, and also Dr. George Chandy, the medical director, for a kind invitation to give this talk. It's also my absolute honor to share this platform with experts such as Dr. Thomas, who's just talking, and Dr. Valiath. These are the giants on whose shoulders we stand on, and it's an absolute honor to be here. So thank you very much. My name is Jijini Vargas, and I come from Muttam in Haripad. My husband is Koshipan, and he's from Kottayam. I have two children, Josh and Rebecca, who are 12 and 7, and we live in London. I work as a consultant at the Royal Free Hospital and also at University College London. And I, as Dr. Thomas was saying, I had the privilege to look after women who are affected with breast cancer. So now when I asked Jacob for what he'd like me to talk about today, he told me that most of the audience would be medical students. And so I'm going to talk in the format of my journey to becoming a breast oncoplastic surgeon. And the main aim of my talk today is to hopefully inspire you with my passion to look after women with breast cancer and to encourage anyone, especially women, who might consider a surgical specialty to pursue it. So my talk will mainly consist of three main parts. I'll focus on the work that I did in research at the genetics of breast cancer at the University of Cambridge, where I spent 5 years completing my master's and my PhD. And then I'll talk briefly about my plastic surgery training in London, focusing mainly on breast reconstruction. And finally, I'll talk about breast surgical oncology training. And I will just touch upon what I think the future of breast cancer care is going to look like. So I did my medical schooling in Coimbatore at the PSG Medical College after I finished my schooling in Kuwait. And this is when I knew that I had to become a surgeon. I really enjoyed everything about being in the theater. I loved the sounds, the lights, but most importantly, I loved being able to fix things with my hands. I grew up in a household full of aeronautical engineers, and it's safe to say that we were all wired to be problem solvers. And so this was a natural specialty for me to be attracted to. After my house surgery, I always knew that I wanted to combine research with clinical practice. And this love for research actually happened when I was in medical school. And I worked with my uncle, Dr. Thomas Chacko, who is also the Dean of Medical Education at the Believers Hospital. And Marina Thomas is my aunt. And I did my first project under his tutelage, where I got the ICMR scholarship to do it. And that's when I got the bug for research. And I knew that I had to have a career where I would be able to combine both. So during my time when I did my MPhil in epidemiology at the University of Cambridge, I received a broad but robust understanding of study designs, statistics, knowledge about bias and confounders, and this was really important, which was transferable skills. We also had a module on breast cancer genetics, and that's when I knew this was going to be the future, and I wanted to pursue it. So this is a photograph of my whole year when we went for a visit to the WHO center in Geneva. After my MPhil, I went on to get another scholarship to move on to doing a PhD and this was done in 3 years in genetic epidemiology of breast cancer under Professor Doug Easton, who is a leader in this field. And for the next few minutes, I'd like to speak about my research in case someone's interested in this group and would like to think about doing this. So why breast cancer? Breast cancer remains the most common cancer in women and still a frequent cause of death from cancer in most developed countries. We know that some breast cancer cluster in families and that the risk of the disease is increased 2 to 3 times in a first-degree relative of an affected woman, which suggests that genes are associated with the susceptibility to this disease. Up to 10% of breast cancer is thought to be hereditary. However, the cause of most cases of breast cancer remains unexplained and is likely to be heterogeneous. Cancer gene discovery field is actually quite recent. And as you can see on this timeline, technology in this area is fast evolving. The BRCA genes were only identified in the mid-90s. High-profile individuals have also had a huge impact, such as Angelina Jolie, raised awareness in cancer gene syndromes by getting tested and having surgery to prevent breast cancer. She went a long way in helping destigmatize female cancers, and a lot more women came forward to be tested. The genetic factors known to be associated with susceptibility, including mutations in BRCA1 and 2, again account for only 15% of the familial risk, and perhaps only 5% of the overall breast cancer risk. We still have a lot more work to do in this area. So what do the BRCA genes do? They're tumor suppressor genes. In normal cells, these genes help to make the proteins that repair damaged DNA. When these genes are switched off, you have a higher risk of getting cancer. This was the time when I entered the field and wanted to study genetics of breast cancer. We now know that breast cancer is actually a polygenic disease, which is affected by many, many genetic variants. And most of the effect sizes are very small for each of these mutations. So if we look at this graph, you can see that up here are BRCA1 and 2 genes. They are rare, but they have a high risk if you have it. But what we have down here in this part of the graph is lots of genetic variants that each provide a small effect, but they're so common that if you have enough of them, you can be at a high risk. Again, all that we know together, taken together, will only again explain only 50% of the heritability of breast cancer. Any 2 human genomes differ in millions of different ways. They can be made up of small variations where there's only one nucleotide difference, and that is called a SNP. Or you could have larger variations, such as deletions, insertions, you could have copy number variations. And any number of these variations can increase the risk of an individual getting the disease. Around the year 2000, before genome-wide association studies, which is what I want to talk about, we used to focus on doing studies among families to understand the genetic reason why you get the disease. And this technique was very successful in single gene diseases. But when we're talking about common complex diseases such as cancers, we needed a new study design, and that was called genome-wide association studies. This is a very elegant way of looking for new variants in the genome. So what does a genome-wide association study ask? This study asks if an allele of a genetic variant is found more often than expected among cases of a disease. So if you look at this picture, you can see this red dot. If you have this red dot or this mutation more times among breast cancer cases when compared to controls, then we can come to a conclusion that maybe this mutation plays a role in the disease pathogenesis. And this is a Manhattan plot. This is what you get when you do the analysis. when we talk about p-values for these analyses, we're talking about p that is 5 into 10 raised to minus 8. That's because we're doing so many tests. We're looking at so many mutations that it is possible that you may find something just by chance. And to avoid that, you have to have a p-value that's really, really up at the level of 10 raised to minus 8. But for my PhD, I decided to do something a little different, where I used an intermediate phenotype as a way to find more genes for breast cancer. So this is how a breast looks on a mammogram. The white area is called dense tissue, and the darker area is made up of fat. Now, if we take 5 women of the same age and same BMI, and we look at their mammograms, they can all look very different because they could have different amount of dense tissue in their breast. So the genes that determine the density, so my idea was to find genes that determine density because it's both very heritable and it's also a strong risk factor for breast cancer. And the idea was that the genes that affect density would be easier to identify than genes that affect breast cancer. So we did a genome-wide association study for breast density. To do this, I had to combine my data with data from Harvard, from Mayo Clinic, from Karolinska Institute, and from Singapore. And that's how we got to a sample size of 4,800 women. When we did that, we read density using a software called Cumulus. And then we had data on about 300,000 SNPs. And then we imputed the rest of it using data from HapMap and used linear regression because percent mammographic density is a quantitative trait. And that's how we identified the first SNP that was found in the gene ZNF365, which is a transcription factor and works by promoting stalled replication fork recovery, and it also prevents genomic instability. Then we went on to show that actually density, as we had assumed, density and breast cancer, they both share a common genetic basis. And we also showed that using an intermediate phenotype, like for example, in cardiovascular studies, they used hypertension as an intermediate phenotype and they were very successful. So density, breast density, is a successful intermediate phenotype to look at breast cancer. Well, we needed more power because there's a lot more that we need to find. And so we combined even more, with more data around the world, and that's how we got the sample size up to 10,000 women. And therefore we found even more mutations. So this field is absolutely growing. There's a lot more that we're learning. And this is a list of genes that we now know are associated with both density and with breast cancer. But as a surgeon, as a clinician, most of us will be sitting there thinking, so what? So you find some SNPs, how do you bring this to clinic? How is this going to benefit a lady that has breast cancer? And this is what is going to be the future. So what we've done is we've found these SNPs, a set of SNPs, that each of them will contribute a small increase in the risk. But what if we were to count them all together and give the woman a score? So if you look at this graph, this lady in red may have a score of 313 mutations that can increase her risk. And this lady in green may only have 5. But if we could watch out that lady in red, give her intensive screening, give her mammograms every year so that we pick up her cancer as early as possible and treat it as well as we can, we could make a big impact on her management. So this is what we're going to be doing. We're going to be using information to risk stratify breast cancer screening. It will help us to understand more about biological pathways, which could be leading to the cancer as well. So a lot of studies around the world are looking into this. At the moment in the UK, any woman who's over the age of 50 will be invited for a mammogram every 3 years. But what if we got a little bit more clever and did this according to the risk that the lady has. If there was a way to combine data, her reproductive history, her SNP count, and then stratify them in a way that the lady that has the highest risk, we could even offer prophylactic surgery like we do for BRCA women, and thereby even prevent breast cancer from happening in these women. So this is really exciting field for me. So in summary, my work in Cambridge showed that there was an evidence for shared genetic basis among density and breast cancer. We illustrated the power of using an intermediate phenotype to identify more loci. More importantly for me, I learned a lot of soft skills, such as collaboration, need for negotiation, and communication skills, in addition to the strong research skills that I needed. But I always wanted to be a surgeon, and that's what I did straight after. I went into a competitive interview process where first you have to compete with everyone who wants to do surgery to enter into 2 years of core surgical program. During the 2 years, you are actually put in different surgical specialties. So you spend months in trauma and orthopedics, then you put in general surgery, different specialties. After that, you choose which specialty you want to go into, and you go for another competition. I always wanted to do plastic surgery. I was captivated with plastic surgery. As Dr. Thomas was saying, the sheer spectrum of procedures that you can do it for people of all ages. And also the way we respect anatomy is very different to other surgical specialties. And this is what attracted me to plastic surgery. And I was fortunate enough to get a training number in London and completed it in tandems. But I want to focus on breast reconstruction because I always knew I wanted to work with women who are affected with breast cancer. And the first slide I want to put up is this. Why do we reconstruct breast? If we are not convinced as clinicians that we are doing the patient a favor, it's difficult to promote this area. It is not about vanity. Lots of women feel guilty for asking about reconstruction. They think it is not necessary. But really what we're trying to do for her is to allow her to look balanced when she's wearing a bra or a swimsuit. We are allowing her to regain her breast shape permanently, so she doesn't have to wake up in the morning and search for that foam bra and put it in a bra. We want her to feel self-confident, be her usual self again. But even given all this, not everyone chooses to have it. We have a lot of women who come in and say, I don't want it, which is absolutely fine. But it's important that we are able to offer this to a woman who has breast cancer so that she can continue with her life as normal as possible. So just broadly about breast reconstruction, if anyone's interested in plastic surgery, this is the kind of things you would be trained in. So we can broadly divide it among methods and timing. In methods, it's implant-based reconstruction and autologous. Autologous means you use the tissue on a woman's body and use that to reconstruct the breast. Timing, you can do it delayed or immediate. However, as Dr. Thomas was saying, we have to be able to offer women immediate reconstruction as a standard now. In the UK, every woman who undergo breast cancer surgery, if it is oncologically safe, will be offered immediate reconstruction, which means that when she wakes up after the surgery, she will have a breast mound. Briefly about the autologous options, there's several. As Dr. Thomas was saying, we've been increasing our armamentarium with, we have local perforator flaps, mainly used for partial breast reconstruction. You can have pedicle flaps using the muscle from the back, the latissimus dorsi flap, which is very common. But the most popular one in the UK is the DIEP flap, where we use the deep inferior epigastric perforator and we use it as a free flap. So we completely disconnect it from the abdomen and place it in the breast. When you don't have a DIEP flap, or if it's failed, you move on to other options, such as you can have buttock-based flap, which has the S gaps and the I gaps, which are based on the superior and inferior gluteal artery perforators. Or you could have thigh-based flaps, that transverse upper gracilis flaps. Lipomodeling is a very useful adjunct. This is where you liposuck the fat from the lady, clean the fat, and you can use it in the breast to reconstruct. But it's usually used as an adjunct. When you want to correct minor deformities or you want to give them a smooth outline, you can use it. It's very, very flexible. Just a picture to understand what locoperforator flap is. It's where you just do a fasciocutaneous flap. You're not sacrificing a muscle there, and you base it on a perforator, and you basically lift it up and you swing it into the cavity you have made when you took the cancer out. So this is a lady that has a contour defect, and you plan your flap. The X's are where the perforators are. You raise the flap and you put it into the breast to reconstruct it. And then implant, what you would do, you can have it under the muscle, so it'll be subpectoral placement, or you could have a prepectoral placement, and then you use a silicone implant. You can have expanders, like in this lady, if it's in a delayed setting. And what we do then is commonly we used a sling made of acellular dermal matrix, which is of animal origin, can be bovine or porcine. They have benefits, and it's become a standard practice here, but you don't always need it. But this is the most popular procedure that we do in the UK. This is called the Dieppe flap. Essentially, what you're giving the lady is also a tummy tuck. You take the tissue from the abdomen and bring it to the breast. So you do a mastectomy, and all of these etched areas are the fat that we use to fill the breast envelope. And this paddle becomes the paddle here, where the nipple areolar complex is. To do this, so this is another schematic diagram of how you chase the blood vessel down to the deep inferior epigastric artery. This operation takes about 6 to 8 hours, but it gives an excellent result. But this is a specialty of microsurgery, because what we're doing is we're completely disconnecting the blood supply to that tissue in the abdomen, and we're taking it up to the chest, and you are going to stitch or anastomose the vessels that come from the deep inferior epigastric artery, and then you plug it onto the internal mammary artery. And so the diameters we're talking about is 1 to 3 millimeter, and you use sutures that are so small that you really can't, you struggle to see it with your normal eye. And this takes years and years of practice and lots of hours that you spend in the lab, and then you do it on the patient and get proficient in it. But this is not enough for me. When I became a plastic surgeon and was reconstructing the breast, I kept working with breast surgeons. And I understood that for me to be completely fulfilled, I had to be the surgeon that takes the cancer out. So I went for another competition. So during my plastic surgery training, there was an offer for 9 posts in the whole of the country for people to specialize in another field. And I went for this competition and got a place to learn surgical oncology surgery, which means that now I can do mastectomies and do wide local excision. So basically, I do the cancer resection work and I do the reconstruction straight after altogether. So why is this interesting for me? Because breast surgery and breast surgery oncology, actually, we're learning so much so fast. It's a rapidly expanding field. And what we know from research is that it's not a single disease. There are at least 10 subtypes. So if you give the same treatment to lots of women with breast cancer, they all respond differently. And we have to understand how each of these tumors differ. And that is what really interests me. So a little bit about what my job looks like now. I have a one-stop clinic where a lady comes with a lump or after screening. She comes and this is what happens to her. It's called triple assessment. It all happens on the same day. I take a history and do a clinical examination of the patient. And depending on that, she will go straight for imaging the same day. If she's over the age of 40, we can do a mammogram because it has enough sensitivity and specificity to work in women of that age. But if she's younger than 40, then we do an ultrasound. Depending on what the radiologist finds, she may have a biopsy that same day. And this is sent to the lab. The histopathology becomes available 2 weeks later. Then we go to an MDT meeting. In the MDT meeting, you have the radiologist, histopathologist, the breast surgeon, plastic surgeon, and the oncologist. That's when every lady that comes to the department will be discussed in an MDT meeting, and a decision is made about how to manage her. Breast conserving surgery is becoming more and more feasible now. Gone are the times when anyone who had breast cancer would have a mastectomy. We now know that we don't need to do this. All we need is to be able to locate the tumor and take a margin of tissue around it. If we do breast conserving surgery, then the lady will have to have radiotherapy afterwards. And this is how most of our ladies are moving towards. So if you look at the margin, what kind of margins do we need? All we need is to have a margin that's more than 1 millimeter in breast, which is actually quite doable. So in a lady who has sizable breasts, you could go in and just take the tumor and a margin around it and provide her with adjuvant treatment, which is radiotherapy, and chemotherapy if she needs it. She may have endocrine treatment and even immunotherapy. And that's how we're managing patients in the UK now. Of course, if you have multifocal tumor, or if the tumor is really big, then she will need mastectomy. If she has a genetic predisposition for cancer, again, we will offer her mastectomy. So what is my job now? I get the opportunity to consult breast cancer patients myself, so I can do cancer resection work, which was really important for me. I can offer the whole spectrum of reconstructive options. I've recently been appointed to develop the perforator flap reconstruction service at Royal Free Hospital. And the best bit of it all is because of my research background, I have been given time in my job plan to spend driving innovation and research in the hospital. I'm also actively involved in teaching. I'm the module lead for burns and plastics and reconstructive MSc course at UCL. And this is me working on a robot council. So I'm sure you're all familiar with the Da Vinci robot, which is being used in a lot of specialties. The reason why we don't use it in plastic surgery is because you don't need a minimally invasive component for plastic surgery, because we are all about big incisions, we work superficially, we work on the skin and subcutaneous tissue. However, there are surgeons who are looking into seeing whether we can take breast out, so we can do a mastectomy remotely so that the scar is not on the breast. There are lots of advances in this field. The future is going to be personalized breast care. Every woman are going to be, we are going to be looking at a woman specifically, looking at her risk for getting the cancer, what her lifestyle involves, what would be right for her tumor, and making a package that is right for her. These are the areas that are growing. These are the areas that I'm interested in. And I'm more than happy for any of you to contact me if you want to learn more, or you want to know about how to access training into any of these areas. So in summary, mainly for my medical students, I want you to realize that there are many ways to reach a goal. Okay, so if you start with research and then go into surgery, you could start with surgery and then go into research. There are lots of opportunities everywhere, and there are mentors who are ready to help us. You just need to go and ask people for avenues, and they will open it out for you. I also want to tell you that I'm a very, very average person, but I was fortunate enough to work with great mentors who helped me. Okay. And the other thing I did in my career was to knock at many doors at the same time. So when I applied for the scholarships, I also apply for surgical jobs. And when two things open, that's when I choose. So keep an open mind, see what happens and how things pan out in your life. It's also important to be self-aware. Get to know yourself when you're in medical school. Start by asking, who am I? Or what makes me happy? And it's also okay to be different. I knew I wanted to be a surgeon, but I looked at myself and I didn't think I looked like the surgeons that I saw, mainly because I'm an introvert. I find public speaking quite difficult because it's not natural to me. And I felt that surgeons should be big, loud, and I really admired them for being like that, but I couldn't be like that. I tried changing myself and I couldn't. And now I realize that it's not going to happen. So it's okay. You are different, but in your different way, you can make a difference to people because we all want to work together to making our patients' lives better. And we can all do it in our own unique way. Find something that you are passionate about. This is key because when you actually enjoy what you do, you will never feel like you're working. Okay? And confidence. You need to have confidence. A lot of the people I work with, especially in London, especially plastic surgeons, are naturally very confident people. They have confidence in their own ability, in their own skills, and they are skilled and they're confident, which is great. But I have confidence not in my own ability because I do not have much. I put my confidence in my God, and I believe that He has a purpose for my life on earth. And that is what gives me strength to move on. That He will negate all my inabilities and He will make it all okay. And that I can do all things with His strength in me. Surround yourself with uplifting people. Having a family, my wonderful husband who has supported me through my whole journey. I could not have done what I've done if it wasn't for the times that he has supported me, let me stay back at work, and helped me so much because when you're in a foreign country, you have very little help. I have a very supportive family as well who would come in for every exam that I wanted to write, look after my children for me. And that without those kind of support, I wouldn't be able to do this. My children, my aim and my hope is that I would be a role model for them and show them that working hard is commendable. Thank you once again for this opportunity.
That's really a fantastic talk and a fantastic story. You have achieved your dream, and this is every person's dream. I wish I could be like you. I'm older, much older than you, maybe old enough to be a father, but I really envy you. Your journey, your concentration, your confidence, your pursuit of your dream and achieving it. This is really a great thing, great example for our medical students. Even though Jacob said this is meant for medical students, I'm sure a lot of plastic surgeons and other specialty doctors who are really absolutely fascinated by your journey. Thank you very much for the talk, Dr. Dedi.
Thank you.
Dr. Thomas, do you have a comment about Dr. Jejani's this young person's journey? I'm sure you wish you were young again and back in England and doing the things that Dr. Jejani is doing.
Yes, indeed.
Yes.
I was so impressed
Yes.
by your, what you want to become. And you work for that one. And you reach there. I think that is the way, I think, a medical student or a youngster, they should decide, I think, what they want to become. I think, my friend, Dr. John knows we were both undergoing the MS training, and plastic surgery was not started in Kerala. And that is the time I decided I want to become a plastic surgeon. And there is nobody to look there at that time. And going to the library and read about plastic surgery. And it's a nice thing to mention. When I came to Oman, a plastic surgeon from Oxford by name John Badstone, he came to Oman to do voluntary service. Once a year, he used to come for 1 week. And this is the first plastic surgeon I come across in my life. And I am seeing as if God has sent this person to me. I followed him. And here am I. Now I am a plastic surgeon. I think, you should have what you want to become in life. And the same thing, I want to congratulate my friend John. While I want to become a plastic surgeon, he decided he wants to become a cardiac surgeon. Now he is a shining example of a cardiac surgeon. He was in Oman, and from Kuwait he came. He proved his name here. Now he is heading a service at the Believers Hospital. And these are all, I will tell you, youngsters. If there is, or as the proverb goes, look at the sky, at least you will reach the top of the tree. So work hard. I was very impressed by Janie, by your journey. And now I want a question about Janie. I will tell you, during my training, when I have cancer surgery, especially cancer clinic, I have seen people will say all about, there's a consultation time, patient will be asked all about the surgery, about radiotherapy and chemotherapy and full stop. They will never say once upon a time about the reconstruction. So many ladies with a mutilated breast, they were walking around without the reconstruction. And this is the one I want to mention. This is not far away. In Astor Med City, when I went, a mastectomy patient came to me. This is in Kochi. And I said, this can be reconstructed. And she was telling, this is after 10 years. No surgeon told me up to this time, this can be reconstructed. I think I want to ask you, Janie, in your cancer clinic, are you exposing, as you telling to the patient, all these modalities of that one, and reconstruction is part of the consultation? Is this truth is exposed to the patient? It is surgery, radiotherapy, chemotherapy, followed by the reconstruction of the breast. And this should be exposed and mentioned to the patient. Am I correct?
Yes, absolutely. I completely agree with you. It should be part of the initial consultation where the patient is told about what procedure we do for cancer and also the adjuvant therapy, as you were saying, but also talk to her about reconstruction. It's important to start that conversation early to understand what her concept is and what she wants in her stage of life, and whether a lot of women, as I said, may opt to not have reconstruction, which is absolutely fine. It's about respecting what the woman wants. But we should be able to offer it to her and say, at this point, I am able to offer you this and this and this. This is what you would look if you don't have it. This is what an implant reconstruction can give you. This is what an autologous reconstruction will give you. And then she will have an idea. Because sometimes we have women who come and say, I do not want implant reconstruction. I don't want anything foreign in me. And that's absolutely fine. Or sometimes they come and say, I don't want a long surgery, in which case we cannot give autologous. But as Dr. Thomas was saying, I completely agree that every woman who has breast cancer should be given the option to have reconstruction in their first consultation. But I also want to say this. Oncology comes before any reconstruction. And there are times when the tumor is so aggressive that it will benefit her to have no delay to her adjuvant therapy. And at those times, we would tell her after discussion that she would benefit from not having immediate reconstruction. She should stick to her plan for the oncology treatment first, see how she does and recovers from that. And then we would consider delayed reconstruction in her if she wants to have it. So yes, thank you, Dr. Thomas, for that comment.
Do you have any questions from the audience? I can see some names there, but I don't see any questions. Gauri, do you have a question?
Yes, sir, I just promoted a few of our students as
Yes.
panelists because I just wanted them to have a live interaction with Dr. Jajani. I thought that would be endearing for our student community. So if a few children whom I have just randomly chosen to interact with Dr. Jajani, if each one of you, one after the other, if you can unmute yourselves, open your video and talk to her, it would be great.
Okay.
Can we start with Amala?
Hi, Amala.
Amala, are you able to unmute yourself? Okay, can we ask Jamie to speak? Okay, yeah.
Hello, ma'am.
Hi, Jamie.
This is hello. Your talk was really inspiring.
Oh, glad. I'm glad it helped. How can
because
I help?
Because I feel like a lot of us are in this journey, and we're still trying to figure out what exactly we should do. So it's great to see that you were able to achieve all your dreams, and it's very inspiring. And I feel like even throughout this journey, I hold on to the fact that all of my strength comes from God. And I know to move forward, I would have to keep believing in Him. And I also pray that, I keep holding on to my dreams just like you did. Thank you so much, ma'am. It was very inspiring.
Would you like to ask something, Jamie?
Ma'am, just about the drive, how you were able to move forward, because I'm sure you faced a lot of difficulties, just like a lot of us do. So if you could share with us.
Yeah, I absolutely want to, because it is important for all of us to be frank about not just the successes, but also the difficulties, because all people see is the top of the iceberg, right? They see you come out, but the amount of hard work, the frustrations that you go through is immense, because you have to put everything you have into that. You have to just focus on your target. So if you decide that you want to achieve something, you go meet people who've done it before. Then you make a list of things that you have to achieve, and you plan and put everything you can and focus on it. Okay, that's all you can do. All you can do is hard work. But when the door opens, it is a lot of God's grace. I will never take credit and say that it was just my hard work, because I have a lot of colleagues who are even more talented than me, but have not managed to open the door. So I give all the credit to God. I mean, that's all I want to say. But I've also had failures, and I've also had difficulties. There were times that I didn't want to get out from bed, and I thought, that's it, I can't do anything. And it got harder as I became older, because when you have children, it becomes even more harder. Because I started thinking that I'm a failure as a mom. I started thinking everything's difficult. I just can't do it. I'll just quit. And it's okay to feel like that. The difference is the ones who get up from that position, those are the ones who make a difference. Everyone will go through failure. That's an eventuality. Okay. But if you can get up, the quicker you can get up, the faster you can get up. If you get up with a kind of resolution that you're going to do even better, that you're going to show them what you are capable of. That's what happens to me. Especially the naysayers, those are the ones that really encourage me. The ones who say, you're foreign, you won't be able to do it. Those kind of challenges make me even more excited to prove people wrong and to show that this is what I can do with my God. there is nothing impossible with him. One day you will be
Thank
telling
you, ma'am.
like this to others.
Thank you, ma'am.
Jamie is our topper in second year. She just got her results, and yeah. Okay, so probably we can listen to Navneet now.
Hi, ma'am.
Hi, Navneet. How are you?
Ma'am, I'm doing well, ma'am. Ma'am, if you had an option for a run-through program in plastic surgery, ma'am, will you prefer that?
Yes, absolutely. I had I also got a run-through program in plastic surgery because that's what I wanted to do. Just help me understand what you mean by a run-through.
Ma'am, like in cardiothoracic surgery and all, in UK, they provide a program where we can start from ST1 to ST8 continuously without having a core training, right, ma'am?
In plastic surgery,
So,
you don't have a run-through program at the moment. You still have to do CT1 and CT or ST1 and ST2. Then you have to go for the competition at ST3. That's a national competition, and it's very, very hard, but it is possible. But if you get a run-through number, that's
okay, ma'am, thank you.
I would never say no to a run-through number. It's a very good path. That's the one I took.
Okay, ma'am. Thank you, ma'am.
Thank you, Navneet. Let's listen to a first-year MBBS student, Kamal Martin. If you can come in.
Hello, ma'am. It's such an inspiration to hear from you. It's like for us youngsters, we just don't know which path to follow. It's like during this pandemic time also, we are just like constantly scared about our future. So hearing from such an inspiration, it's like we do have a good future, and that we just like this is like a big board for us. We just don't know where we are going, but we will reach a good shore, I think. Like I just want to know like how to like grow from here. Like after MBBS, what should we do? Like how should we be thinking? Like how should our approach to first year to be like you? Can you?
I think it's useful to take one step at a time. So if you're in first year of medical school, you should, just focus on doing the first year very well and keep doing every year well, and make sure that you spend enough time in all of the specialties and keep thinking which specialty makes me happy, what makes me feel fulfilled, what would you like to be doing. And every time the other thing is to also look at the patient cohort. I thought when I was in medical school I would love to work with children, but actually seeing sick children made me really I used to get too emotionally involved, and I knew that would be not a good option for me. So when you work with different specialties, you can actually kind of understand where you're comfortable and what makes you feel happy. And then once you decide on that, then just go for it. Just go write as many exams you can, go for as many entrances, look at different options. The world is open now. You can look at lots of things now. With the internet, you can contact any of us in different parts of the world, see what's available. Yes, I didn't think I'd come to the UK, but my husband was here. So God has a way of opening different doors as well. So it will all become open. It will all become clear. Do not worry too much, okay? Just do one step at a time, and slowly the things. I mean, I really believe God has a purpose for each one of us, and He will reveal it in time. So just trust in Him.
Thank you, ma'am. Thank you so much.
Oh, thank you, Kamal. And we also have Amala with us. Amala, or whoever got promoted to panelists, if any one of you wants to talk, please do talk. If any of your friends have written to you to ask anything, please do ask now. Okay. So yeah, I think that's about it. So
thank you very much.
Yeah. So time to close. And first of all, I would like to thank Dr. Jajni Varghese. Chechi, you were fabulous. Okay. So we really enjoyed every moment of the talk, and I'm really grateful to you for sparing that precious hour. I know how precious that hour is for you, and you've spared that just for us, and you've come online and you've given us this amazing talk. We, the community at Believers Church Medical College as a family, are grateful to you, especially on behalf of our students. We thank you for coming over and talking to us, giving us this world perspective of how we can open up and reach out to the world and of course, achieve great things. Thank you so much. Thank you so much, Dr. Jajni Varghese.
Thank you very much. Thank you, Jacob.
And my special thanks to our moderator, Thomas sir. We heard from the horse's mouth. We heard from the doyen. Okay, so that was a great privilege for our students, sir, to have you on board as moderator and listen to those wonderful pearls. And we are indeed extremely grateful to you too for sparing that precious time and coming over and spending time with us. Thank you so much, Thomas sir. You're muted, sir, if you can.
Okay. Thank you very much. I really enjoyed. Thank you.
Thank you, sir. And to our co-moderator, Dr. John Valiat, sir. Sir, your presence is always comforting. Your presence is always a joy. Thank you so much, sir, for coming over. And I mean, as Dr. Jajni rightly said, we are standing on your shoulders, right? Each one of you, like John, sir, and Thomas, sir, it's such an inspiration to work with you, to work under your guidance. Thank you, sir, for coming over and moderating this session. We really look up to more sessions with you, with more speakers like Dr. Jajni, who was such an inspiration. And last but not the least, I would like to thank our student community, both from our college and from other colleges who've joined in. Especially today, we have a few students from colleges in Tamil Nadu, like Madurai Medical College and Kanyakumari Medical College, and colleges from Chennai. Dear children, I hope this session was really good for you, and we really will work on bringing in more sessions like these and bringing in good speakers like Dr. Jajni, though we wouldn't get as good as her. Thank you. Thank you so much. Thank you, everybody. Thank you, Dr. Jajni. Thank you, Thomas, sir. Thank you, Dr. John Valiat, sir. And we wrap up this session. We are back with a bang on the 15th. We have Dr. Karthik from the Infectious Diseases Department of CMC Vellore coming to us with his perspective on the treatment of tuberculosis. So see you all at 6 p.m. on tuberculosis on the 15th of December. Thank you so much, everybody. Signing off is Dr. Jacob from Believers Church Medical College. Thank you all. Thank you. Have a blessed evening.
Bye.
Hi, Jacob. Very well organized, and we will do something for the grown-up public next time. I mean, when you have one of these days, you know.
Definitely, sir.
Yeah.
Definitely.
For the doctors. And
Absolutely, sir. Absolutely. Whenever you say, sir.
Excellent. Very well organized.